right, thank you so much, Michael. So I'm going to keep us on track and move on to our second mentor and second speaker. So it's my pleasure to introduce Dr. Janice So, who's going to introduce Dr. Jin Kim.
Okay, good morning, everyone. So I'm Janice So. I have the honor today to introduce you our next speaker, who's also another recipient of this year's Psychiatry Trainee Research Award, Dr. Jin Kim. So Jin is our third-year fellow of our NIDA, National Institute on Drug Abuse postdoctoral training program on drug abuse treatment and services research directed by Jim Sorensen. And Jin received her PhD in social psychology from UC Davis, where her graduate work focused on primarily in the area of mental health treatment disparities among Asian Americans. And her graduate advisor, Nolan Zane, at the time told me specifically that something about Jin Kim. He said if he could clone one trainee, he would choose Jin Kim. And now, as Jin graduating from our fellowship program, now I begin to resonate the same thought that, yes, I would like to clone her too. I think Jin would agree with the following description of her when she started training with us, a little teasing here, that when she came to us, she didn't have much experience in terms of doing anything with tobacco or addiction-related research. But she brought with her very strong skill sets and a strong passion in conducting health disparities research. In particularly, she really sees addressing health disparities is addressing social justice issues. She has convinced us, impressed us that she will be a great fit for our program, and we were right. So during one of her first research study with us here at UCSF, she discovered the association between food insecurity and tobacco use disparity, where she'll be presenting some of those work today with you. And since then, her research has also received recognitions both within and outside of UCSF. For example, in the last spring cycle of the RAP, CTSI funded her innovative pilot study that focused on exploring mediators between food insecurity and tobacco use. Then in September, she competed in the first UCSF Postdoc Slam, where she gave a 3-minute speech about her research on food insecurity and smoking. Not only that she was the only social scientist that got selected to be one of the 10 finalists to compete, she went on winning the first place of the Postdoc Slam with a nice cash prize. And more recently, her KO1 application, where she proposed to develop and pilot test a smoking cessation intervention targeting those smokers with food insecurity, received a score in the exceptional range, that means in the teens, and her NIDA program officer last week told her that her KO1 score indeed is among the best scores of all the K applications within the same cycle. And, well, I'm sure this list of accomplishments will keep growing each time when Jin gets introduced. But on a last personal note, I want to say that it has been an incredibly rewarding experience for me personally as her mentor in the past almost three years, that I got to share the first-hand excitement when to share with her these research discoveries that she has, and it has been a privilege for me and also my colleagues from the T32 program to get involved in Jin's journey as she launched her research career. So congratulations again. Jin for being one of the recipients of this year's Psychiatry Trainee Research Award. And now I'd like to present to you Dr. Jin Kim, and her talk today is Examining the Role of Food Insecurity in Cigarette Use and Smoking Cessation. Jin.
Thank you, Janice, for such a warm introduction. I'm very honored and grateful to have this stage and to have this opportunity to share my research with you all through this venue. So thank you very much. I'd like to begin by making my acknowledgments, of course, to Janice, who is my primary mentor, but also to my team of mentors, collaborators, and research team members without whose help and support I would not be here today. All of these individuals had a big part in my thinking as a health disparity scholar and in my research program. I'd also like to acknowledge the sources of funding and support for the work that I have and that I'll be presenting on today. So to give you a general preview of the next 30 minutes, I will begin by giving some background that lays out the motivation behind my program of research. I will present findings from 2 studies, briefly discuss an ongoing pilot study, and end by giving you some key take-home points that I've learned through my work. Let me begin by saying that the decline in smoking is truly a public health triumph. It was in the 1960s that adult smoking prevalence peaked at greater than 40% of the population. And in 1964, the Surgeon General's report highlighted the harms of cigarette smoking on health, particularly as it had to do with lung cancer. The public largely responded to this report, and the prevalence of smoking began to decline. And of course, there were a lot of other important movements in the process. But by 2014, by that Surgeon General's report, the prevalence of smoking had decreased to 18%, which was the lowest that it had been up until that time. So there has been tremendous progress in reducing the prevalence of smoking. But with that said, smoking remains a major public health challenge. So this is a quote from the Surgeon General's report that says that although cigarette smoking has declined significantly since 1964, very large disparities in tobacco use remain across groups defined by race, ethnicity, education level, socioeconomic status, and across regions of the country. So these emphases are added, and we know in this room that these groups do not necessarily represent distinct entities, but there's a lot of overlap and intersectionality. But with that said, I would like to focus on this aspect of socioeconomic status. It is the case that smoking is disproportionately concentrated among individuals with low socioeconomic status. So drawing your attention to the green bar, that's the national prevalence of smoking in 2015, which you will notice has already dropped from 2014 in line with this steady decline. We know that socioeconomic status is a complex construct, and there's many different ways to define socioeconomic status. But if we use some key indicators, such as poverty, for example, so we're looking at the blue bars, you can see that those who are below 100% of the federal poverty level have much higher smoking prevalence than those who are at or above poverty. We can use another indicator such as level of education, and you can clearly see that there's an educational gradient. If you're looking at the orange bars, for example, that lower levels of education are associated with higher levels of smoking, higher prevalence of smoking. And we can use other indicators of socioeconomic status such as income and get at a similar pattern. When we look at this overall pattern, and in sort of combating and understanding how we're going to tackle this issue, these tobacco use disparities, the question then becomes, why are we seeing this pattern, to understand what might be going on. And as you can imagine, the why is very complicated. It's not a one-line answer. There are many different reasons why, but one of the answers has to do with successfully quitting. So socioeconomic disparities in smoking persist in part because of lack of successful quit attempts. Let me walk you through what I mean by that. So when we ask smokers how many of them are interested in quitting smoking, this is their sort of responses here. What to notice here is that most smokers, regardless of their socioeconomic status, that's measured by poverty here, are interested in quitting smoking. When we then ask the percent of smokers who attempted to quit smoking, this is in reference to the past year, what to notice here is that it's lower than those who said that they're interested in quitting smoking, but it's still a sizable proportion, and we still do not see a statistically significant difference when we're looking at it by poverty level. But finally, when we ask smokers who not only attempted, but were able to successfully quit smoking, this is in reference to the past year, this is where we start to see the difference, that smokers who are at or above poverty are more likely to succeed in quitting than those who are below poverty. So really, the story here seems to be that it's not necessarily the difference in interest in quitting or attempts to quit, but it's in being able to successfully quit. Again, when we see this pattern, we have to ask, why are we seeing this pattern? We need to better understand the why in order to promote better smoking cessation outcomes. And again, that why is very complicated, but one of the reasons has to do with stress. So in the literature, there's been a long-time link between stress and smoking. In the past, the debate has been in terms of, which comes first? Is it the stress or is it the smoking? But nowadays, they're understood mostly to be risk factors for one another. When we think about aspects of stress, particularly ones that disproportionately affect individuals with low income, one area of stress that stands out is financial stress. And we do find that in smoking cessation trials, greater financial stress predicts lower likelihood of being able to quit and being able to stay quit. We can also understand this, or think about this as a reciprocal relationship, whereas you might think that financial stress, or the stress, the worry, anxiety, might lead one to reach for a cigarette, to experience a subjective sense of relief or tension. Or you can also think when people are experiencing financial stress, if it's acute financial stress, then even though they might be wanting to quit smoking, it's sort of not the priority in that sense. But you can also see this going the other direction in that cigarettes are not cheap. They cost money, and so the purchase of cigarettes might also feed back into this financial stress. So we can think about this as kind of this reciprocal relationship. In my work, as I think about this aspect of financial stress, which is also quite broad, you can think about financial stress in terms of financial stresses related to housing, to healthcare costs, to childcare costs. As a health disparity scholar and a social psychologist, I'm really interested in examining specific aspects of financial stress that we might be able to target through interventions, through policies, and so on. And that brings me to food insecurity. So food insecurity is one of the most stressful conditions in the experience of poverty. And there are numerous definitions of food insecurity, but this is one that I generally use in the work that I conduct. And I like this definition for a number of reasons. So first, it really gets at this issue of access to food. In the US context, we generally deal with access or problems in access versus problems with availability, which might be more salient in other global contexts. This definition also talks about physical access, so our built environment and retail outlet availability. It also talks about economic access in terms of monetary means. And it gets at this idea of consistency, lack of consistent access. And that is to highlight that food insecurity sometimes is not a condition that somebody experiences at all times, but it's something that might wax and wane over the week, the month, or the year. For example, before the next paycheck, individuals or families might experience food insecurity. So this green banana is one that depicts this food insecurity being something that can come and go over time. And in the right, I just want to draw your attention to the solid blue line. We're going to come to the dotted line later in the talk. But in the solid blue line, it's showing the national prevalence of food insecurity over time. And you can see that from 2008 to 2009, there was a big increase in the prevalence of food insecurity, and that was largely due to increases during the Great Recession. From 2008 all the way to 2014, food insecurity prevalence remained at this historic high, and none of those changes were statistically significant. In 2015, we saw the first statistically significant drop to 13%. So we're moving in the right direction, yet to put that figure into perspective, in the Healthy People 2020 goal for food insecurity, for example, is 6%. So we still have a long ways to go. This is a map depicting food insecurity across the U.S. And this is just in relation to the U.S. average, whether a certain state is above or below. So the darker purple represents states that are above the U.S. average, so they're worse on food insecurity, and the lighter purple represents those who are below the U.S. average. I showed this map to sort of get us to start thinking about how food insecurity and smoking might be related. This is now a map of the smoking prevalence across the U.S. states. And this is a very just kind of crude depiction, but all this is showing here, you don't need to really pay attention to the percentages. You likely can't see them, but the darker states represent states with higher prevalence of smoking. And there seems to be this kind of rough overlap in terms of food insecurity and smoking prevalence. So in study 1, I wanted to better understand systematically what is the association between food insecurity and smoking. So this isn't the first time that this research question had been posed. It was early as 2008 that the first published study appeared on this topic. And Armour and his colleagues examined data from the panel study of income dynamics, which is a representative study of the U.S. And what they found was that among families who were considered to be food insecure, 44% of them had at least one adult smoker in the household, compared to food secure families that had 32%. So smoking prevalence in this sample was still high, but it was much higher among food insecure families. Similarly, in the same year, another study was published, and this study showed that among smoking households, so this is households with one or more adult smokers in the house, 26% experienced food insecurity at some point in the past year, compared to non-smoking households that at 12% experienced food insecurity. So there was already this link in the literature, and I wanted to further understand this association and push our understanding forward. So in my study, I examined a specific tobacco use disparity group. This is among young adults who are considered to have low socioeconomic status. I already went over the association with low socioeconomic status and higher prevalence of smoking, but here I focused on young adults because as an age group, young adults have the highest prevalence of smoking compared to all other age groups. So they are a tobacco use disparity group in that sense. And I accounted for behavioral health covariates that are associated with higher prevalence of smoking, namely psychological distress and alcohol use. If we control for these factors, do we still see an association? And lastly, I examined patterns of smoking. So with the decline in smoking prevalence, the patterns of smoking have been changing with more light and intermittent smoking and social smoking and so on. But here I examined this as daily and non-daily smoking. So the data for this study came from the California Health Interview Survey, and to be included in the analyses, I restricted it to young adults who were between 18 and 30, and as proxies of low socioeconomic status, examined those young adults who reported that they were very close to or under the federal poverty level, and who had no more than a high school education. The dependent variable here was smoking status, whether somebody was a current smoker or a non-smoker, which also included former smokers. And we also examined smoking frequency in terms of whether somebody was a daily smoker or a non-daily smoker. And as independent variables on the model, examined the usual socio-demographic characteristics, alcohol use and binge drinking, which are associated with higher prevalence of smoking. This is in reference to the past year. the experiences of psychological distress, and as well as food security, insecurity status in the past year. And jumping to the results to show you the smoking prevalence by food insecurity status, across the entire sample, the smoking prevalence here was 21%. But when we disaggregate that by food insecurity status, you can see that young adults who experienced food insecurity in the past year had higher prevalence of smoking than young adults who are food secure. Next, I'll show you results from the multivariable logistic regression analysis. And before I do that, let me orient you to this graph. So here on the y-axis, we have adjusted odds ratios. So this is adjusting for all other factors in the model. And here on the x-axis, we have select independent variables that were in the model, such as age, gender, race, ethnicity, education, and our behavioral health covariates, and food insecurity. These are just select variables that I'm showing you. It wasn't the full model. The full model also included things like poverty, English language proficiency, nativity, where somebody was born, for example. So in showing you the factors associated with current smoking, the figures in bold are the variables that were statistically significant, and the vertical lines represent 95% confidence intervals. So sort of going from left to right, we can see that young adults who are 26 to 30 compared to those who are 18 to 25 had higher odds of being a current smoker. Women had lower odds of being a current smoker than men. Hispanic Latinos compared to non-Hispanic whites had lower odds of being a current smoker. There was no effect of education, and we can see that alcohol use in the past year, with or without binge drinking, was associated with higher odds of being a current smoker compared to no use. Interestingly, there was no effect of psychological distress on smoking. And lastly, we find that food insecurity was associated with higher odds of being a current smoker. And this is in this adjusted model, controlling for all other factors. Next, I'll show you figures with factors associated with daily smoking. This is just among the smokers. Many of the findings are similar to factors associated with current smoking in terms of age and gender, race, ethnicity. What does stand out here in terms of factors associated with daily smoking is this education. We find that young adults who did not complete high school compared to those who did complete high school were more likely to be daily smokers. Again, alcohol use is associated with greater odds of being a current smoker, or daily smoker, and still no effect of psychological distress. And again, we see that food insecurity in this adjusted model was associated with higher odds of being a daily smoker. And then lastly, to show you figures associated with non-daily smoking, what stands out here is that alcohol use continues to be associated with non-daily smoking compared to no use, and here severe psychological distress in the past year compared to no or mild distress was associated with greater odds of being a non-daily smoker. So what are some of the key findings of study one? I'm just focusing on the key findings. There are a number of different findings here, but the study was able to show that food insecurity is independently associated with increased odds of being a current smoker, and not only that, but being a daily smoker. And of course, this study, as a cross-sectional population-based study, has the usual limitations of those studies. But one of the questions that it raised in my mind as I was kind of thinking about these results and thinking about kind of the next step of these results is that as I was describing to you this study, I was referencing, any food insecurity in the past year. But I also showed you in this graph here, in this little picture here, that food insecurity is not necessarily something that's always stable over time. It's something that kind of waxes and wanes with different periods. So it made me think about sort of both the severity and the chronicity of food insecurity. In study one, I considered sort of just any food insecurity, but we know that there are also differences in severity. So this is where I will draw your attention now to the dotted line. Here, this is very low food security, which is the same thing as severe food insecurity. And you can see most recently, severe food insecurity affected about 5% of the population. So to qualitatively differentiate food insecurity and severe food insecurity, in severe food insecurity, it's when actual eating patterns are disrupted and food intake is reduced because of lack of money or other resources to afford food. So it's a higher degree of food insecurity. So in study 2, the major question here was to understand, what is the association between the severity of food insecurity and smoking status, looking at that across time. Again, here we examined a specific tobacco use disparity group. This is among women who are homeless or marginally housed. The homeless population is one that has a very high prevalence of smoking. And as you can imagine, they also deal with high prevalence of food insecurity. Similar to study 1, I accounted for behavioral health covariates associated with smoking. So here it was mental health status and substance use. And this was examined over time across 2 years, and the assessments were conducted every 6 months. The data from this study came from a longitudinal cohort study of housing and health among homeless women in San Francisco, and this is a study led by Dr. Elise Riley here at UCSF. The dependent variable, much like study 1, examines smoking status, and in the independent variables, very similar with study 1, with sociodemographic characteristics, mental health status that was measured by the SF-12 mental component score, substance use in terms of risky alcohol drinking and illicit drug use in reference to the past 6 months. And here I examined food insecurity status in these different degrees. Not just yes or no, but no or marginal food insecurity, mild to moderate food insecurity, and severe food insecurity. To sort of describe the food insecurity severity of this sample, you can see that this was at study baseline in reference to the past 6 months, that 38% of the women reported severe food insecurity over the past 6 months. And you can contrast this with the national figures that I showed you, which was around 5 to 6% around the time that this study was conducted. So this is a very impoverished sample. Next, I'm showing you smoking prevalence by food insecurity status. So what to pay attention to here is that among all the women in this study, they had very high smoking prevalence to begin with. 71% of them were current smokers. And of these current smokers, of the 71%, it's not shown on this graph, but the majority of them, 90% of them, were daily smokers. When we disaggregate the 71% by food security status, you can see that among women who reported severe food insecurity, 4 out of 5 were current smokers. So it was a very high smoking prevalence in this sample. And showing you the results from the generalized estimating equations, this is a regression analysis, but it's accounting for the longitudinal data. And here I'm only focusing on the food insecurity characteristics, but this contains all the model contains all the sociodemographics, alcohol use, substance use, and so on. So it's an adjusted odds ratios. And what we found here was that mild to moderate food insecurity was not associated with smoking, yet severe food insecurity was associated with smoking. And this was longitudinally associated with smoking. So in this case, we really had to look at the degree of food insecurity and found that the severity of food insecurity was associated with smoking. When we plot this over time, this is the food insecurity score on the y-axis, and then you can see the different assessment points over time. It really are 2 flat lines that smokers have higher levels of food insecurity than non-smokers, and this persists across time. There's really no change. And this was an observational cohort study. It was not an intervention study. So what this suggests to us is that without any interventions, in terms of both food insecurity or smoking, that these factors are likely to persist. So it really makes us think about what are some of the interventions that we can think about to combat levels of both food insecurity and of reducing prevalence of smoking. So what are some of the key findings of study 2? Just focusing on the major findings here, I was able to find that severe food insecurity was independently increased the odds of current smoking, and this is in a population group with already very high smoking prevalence, and this persisted across the 2-year study period. So it moved forward the findings from study 1 by examining this over time and looking at the degree of food insecurity. Without going too far into what the limitations of this study are, the questions that it raised in my mind, given these findings, are in understanding sort of what are the pathways. So with study 1 and study 2, I was able to establish that there is this independent association. But now the question kind of becomes, how are they related and why are they related? So the next question then becomes, what are some of these pathways? So this brings me to just a brief discussion of an ongoing pilot study that I am conducting. And this is a study to better understand food insecurity and smoking behavior. In this study, taking a multi-level perspective, examining not just the psychological, but the social and the environmental factors, taking that social ecological approach to this problem, to understanding how they might be related. So, although, for example, I mentioned that stress might be related, financial stress might be related to smoking, you could imagine that some of the places that some people live can also make them more susceptible to taking up smoking in the first place. So these are some formative research questions that I'm addressing through this pilot study. And because it's a very formative research question, taking a mixed methods approach to conducting surveys, quantitative surveys, but augmenting those surveys with in-depth interviews. So the surveys itself, they really capture things like sociodemographics and a lot of kind of psychological variables in terms of levels of distress, depression, even food insecurity. But it's really through the interviews to better understand how the two might be related. And here I'm moving towards conducting work that is community-based. So I'm very proud to say that this work is conducted in partnership with San Francisco CalFresh. So CalFresh is the California name for the Supplemental Nutrition Assistance Program, and sort of working with them to recruit participants for the surveys to start to think about, what are some of the needs of this particular food insecure population, and starting to leverage a social service infrastructure that I can build a research program around in this topic. I'm not showing you the data since the data collection are ongoing currently, but so far collected about 95 surveys, and of them 50% of participants reported being a current smoker. So it's a very high smoking prevalence in that sample. So what are some take-home points of consideration that I want to kind of leave you with, given some of the findings from studies 1 and 2 and the ongoing work that I'm doing? I want to sort of highlight the fact that smoking prevalence is high among populations who are struggling with food insecurity. And this kind of leads us to think about food insecurity as a socioeconomic stressor, so one that is associated with higher smoking prevalence and may complicate smoking cessation. May make smoking cessation more difficult. So thinking about this intersection between food insecurity and smoking prevalence. And I also want to leave you with some implications for smoking cessation research. I had alluded to this with a CalFresh sample, but my thinking is, what are some ways that we can leverage these social service infrastructures to promote smoking cessation in these settings that can capture people who are struggling with food insecurity, but also have high prevalence of smoking. And perhaps there's a way that we can promote smoking cessation by addressing food insecurity and other subsistence needs, that the challenges of the stress from smoking cessation, if we meet these subsistence needs, then perhaps we can hope for better smoking cessation outcomes. So that's all I have prepared for today. Thank you very much for your attention, and I'll take any questions. Yes.
It's really interesting. I wondered about the aspect that you thought about
Absolutely.
Insecurity and hunger related but also separate issues, and the drive to have nicotine suppress the appetite.
So the question is whether I've thought about the role of hunger in that association between food insecurity and smoking. And absolutely, hunger and food insecurity are two different facets, but hunger is a risk factor, or food insecurity is a risk factor for hunger. And it definitely is one of the theories that I have, or hypotheses that I have in my work. So it is one of the questions that I'm eliciting through the in-depth interviews. But thank you for raising that, and it's something that I actively think about, and I'm trying to incorporate in better understanding through surveys and the qualitative interviews. Thank you. Yes, you had addressed it.
A strong relationship between alcohol and smoking. You didn't address that. What are your thoughts about whether that would be a place to intervene?
That is absolutely a place to intervene there, and in the findings there was an association with alcohol and smoking. There's already that, to me, that's already an area that is being addressed in many other studies, and I want to maybe collaborate with other researchers who are doing that work, but bring in the food insecurity piece to that, to say, maybe there's a way that we can think about these as not just separate issues, but as kind of a joint issue. That's how I can address that question now. Thank you. Yes, Derek.
How about the potential role of unemployment? The people who are lacking money, also, most work environments you're not allowed to smoke, so you have people who don't know where their food is coming from, they've got time on their hands. Maybe also in conjunction with the appetite suppressant idea.
So what is the role of unemployment?
Do you think there's a potential role there that also could tie these things together?
Absolutely, I believe there is. In some of the surveys that we're doing with the CalFresh sample, for example, of those 95 individuals, the majority of them are unemployed or very part-time employed. So there is a role, and that can make us think about kind of using maybe vocational rehab services also as venues for smoking cessation and addressing food insecurity. Yes, that hand.
I see Dr. Hung squirming, so I know he's going to end this very shortly. And before he does, I want to congratulate both the awardees, but I want to also congratulate your mentors. Both of the projects were just the right size to complete during training and teaching all the relevant methodology and the complexity of variables. So I say thanks to the mentors.
For the record, I'm not squirming.
Yes.
So one of the things I'm struggling with is how much of these results specifically relate to food insecurity as opposed to food insecurity reflecting a level of poverty or impoverishment. And I'm struck by the fact that in your multivariate models that one of the variables that doesn't appear in there is something like socioeconomic status or income or some more general measure of poverty level. And I wonder if you were to include such a measure, if the food insecurity prediction would survive, or if they co-vary too much that it's difficult to dissociate one from the other.
Thank you for bringing that issue up. In the multivariate model, we did include measures of socioeconomic status in terms of poverty and in income, and we didn't see that it was associated with smoking, whereas food insecurity was. So in that sense, to me it suggests that food insecurity is a separate construct, is distinct because of that independent association, yet I understand what you are saying in terms of, to what extent is food insecurity just associated with poverty. And what I think about that is that food insecurity is a very specific kind of stressor, and one that we might be able to mitigate through policies and interventions, which is sort of one reason why I focus on this experience of food insecurity and have interest in this topic. But I appreciate your comment about how it might be associated with poverty. Yes, there's a hand in the back.
Cigarettes are fairly expensive, especially now. They went up. So I wonder if people are just spending all their money on cigarettes and that's why they're feeling insecure.
Yes, that is absolutely a hypothesis, and that every time I give this presentation, that comes up, and that's something that I always have to do. I have to sort of even discuss in all the papers that I write. It really could be like a trade-off in terms of when you have limited amounts of money, are you going to spend your money on food or cigarettes? I think that also sort of goes in hand with the other comment in terms of hunger too, that sometimes cigarettes can mitigate your levels of hunger, or it can be an appetite suppressant, so that there might be another trade-off there in terms of what you decide to purchase. And so again, it kind of goes into that. I understand it to be the reciprocal relationship, that it's not necessarily in one direction. But thank you for that comment. Yes?
First of all, just thank you for this talk. It's excellent. And I, as someone who's using SHIS right now for a project, I'm very sympathetic for the many challenges of working with. But my question is sort of, I'm wondering if you could speak to the process, the mixed methods approach, which is sort of becoming this gold standard in sort of this socioeconomic research, and whether you thought about going in, that you were going to do this sort of stepwise approach, like I'm going to do a large population level analysis, then I'm going to proceed to this sort of mixed methods qualitative work, or whether that sort of emerged organically, just sort of what your experience with the research design process was like.
Thank you for asking that question. My thinking in terms of using the big data sets, the representative studies, was to really find the association first. And then when I realized that I had questions that cannot be answered by these large data sets, that I really needed to collect my own data, because it's such formative work, that the large data sets just didn't contain the variables that I was interested in. That's what really got me to think about, I think I need to start honing down by doing my own mixed method study where I have control over the variables, and then even the quantitative surveys, even if I do that, then I still don't get at the qualitative piece, people's understanding and their explanation. So that was sort of my thought process in that. Thank you. Okay. Thank you very much.